Hello, my name is David Dorr. I'm a professor and vice chair of medical informatics at Oregon Health and Science University, as well as chief research information officer. And I'm pleased to talk to you about the role of health information technology in the management of complex chronic conditions. I have a key collaborator on this work, Lipika Samal, who's at Brigham and Women's Hospital. A little bit about my team. So I work on a team called Care Management Plus, and we do research and innovation in population health, really focus on a mission that is to better understand how data, information, and knowledge can assist in transforming health for our most vulnerable populations. Now, these populations can have complex conditions, they can have multiple chronic conditions, older adults who are frail or pre-frail. And the first step in our research is to identify who are vulnerable, who are potentially at risk for poor outcomes, that we may be able to act in a different way than our usual healthcare systems would to mitigate those risks. So we do risk stratification and segmentation of the populations. Then we tailor care to those needs by creating models of care that incorporate all kinds of different aspects. And then we use pragmatic clinical trials to understand how the different approaches improve outcomes. In this talk, I'm going to really try to help you understand how, first, people with complex chronic conditions are prone to harm from lack of coordination and communication, and how health information technology that brings together data, information, and knowledge and facilitates communication can help people with complex chronic conditions optimize their overall health. And as I'm sure you're aware, health and IT solutions also bring risk. They add complexity, they can worsen fragmentation, they can worsen burden, and they can be challenging to use. So how can we really leverage them effectively? Why talk about health information technology now? I think probably many of us have had experiences with health information technology with its problems. It was really rolled out over a decade ago to many healthcare settings in the form of electronic health record systems. And those systems have been widely decried for their lack of usability, their struggles with workflow, especially between multiple different team members, their worsening of fragmentations. They held their data alone and made it harder to get the data out in some circumstances. And then they also were not interoperable, in that they couldn't really, the data didn't mean the same thing at different places. Now, that's not necessarily worse than paper, but it certainly didn't live up to the promise that people had expected. So now there have been a number of new policy changes and new rules that have led to an opportunity, coupled with the maturation of health IT systems, that really makes it a great time to talk about them. So one of the new laws that came into being is the 21st Century Cures Act. And what this essentially established is a set of standards for the ability to interoperate the data and the systems and use specific kind of application programming interfaces, information exchange, without special effort by patients. So patients can get access to their own data without special effort. Should allow us to really enhance our care coordination and care management capabilities in supporting patients. But in general, organizations are not ready for these. So can they really help, and how? In normal care, different entities or settings of care and different groups are interacting with patients. And so I created this diagram for an engineering conference to sort of explain how information about the care plan for a patient, here Betsy Johnson, a made-up name, is basically being exchanged by many different people. So if Betsy has 5 or more chronic conditions, then on average, she's going to see about 13, 14 care teams a year, and they will basically be touching her care plan, which is just at the bottom there, at different times without any kind of coordination. There's no real central place where this is stored or reconciled against each other. Even our efforts to do medication reconciliation is often at a lack, much less sort of the recommendations for diet and activity and other sort of really important aspects of their care. So what we did, starting about 20 years ago now, was built a primary care team-based care coordination and care management effort that we called Care Management Plus, the name of the team. And we built not only this team redesign aspect, but also health information technology to support getting a comprehensive reconciled care plan that's really patient-centered and helps to make sure that information flows appropriately and reconciles it. And this was very successful. We showed improvement in the quadruple aim of care. And what we've been asking since then is, how do we spread ideas and models like this across systems? How do we make sure that they're thoughtful to different groups and are most beneficial? And how do we support them? How do we help make changes overall? Many different organizations have helped to fund this work that are listed there. For the health information technology components, we found these sort of broad categories most helpful. So first of all, algorithms that predict risk, care planning and care coordination supports through different ways of using health information technology, and then self-management supports. In a recent paper that Lipka Small and I wrote in 2021 in Health Services Research, we really focused on these three elements to understand where health information technology was now and where the gaps were currently. And we found evidence for some progress in each of these areas, but we also found a number of extant problems, including continued issues with low data quality, inequities that could be worsened by HIT, and then in complexity, that HIT layered on top of an already complex system can make things worse. So in algorithms, what we found was really interesting in that if you apply algorithms sort of broadly, just identifying people most at risk for that or this or that, it can be very hard to use them for people with complex conditions. The question often asked in our studies was, so what? What's next? What do I do about that risk? And so some of the articles that we found in our work, we were really focused on people who were answering the so what. Here, you see a screen by Sarosi, who was really looking at integrating evidence-based guidelines and recommendations for people with multiple chronic conditions here, and seeing where they might conflict, and having a different display of that information so that people could make integrated decisions, which we thought was a nice improvement. Robusto, on the other hand, had more of a standard risk score that they had created, but it was focused on drugs. And I thought that was really a nice difference in the sense that with drugs, you can really identify which categories of medications are leading to an increased risk, in this case of poor outcomes over time, and then think about why are they on this number of medications? Is it a time for deprescribing either in a very focused way for potentially harmful medications, for instance, as they get older, or just overall? We built in a number of risk prediction rules into our work because we got lots of asks for different ways to characterize risk. And really what we found out from this and a series of studies we did with the Commonwealth Fund is you really have to be thinking about how are you going to use these risk scores. You can use counts of weighted comorbidities. You can look at mental health related scores. But one thing we heard a lot is that people really wanted to be able to adjudicate the scores. They wanted to annotate them to really say, oh, this is wrong for this patient, and here's why, because I would want to do this on this particular person. And so thinking about that was really important for us because we enabled a system that really allowed that kind of adjudication. The other part is in action, you have to have a way to track what actions you'd like to take. And in that, I think it's really important to give tools that remind people about the actions that they've told you that you want to take. And so we built this care manager tickler list where they could put in their own reminders for things they wanted to work on with their population of patients with complex needs, but also would have automatic reminders for certain conditions or needs. In addition, what we heard is that risk prediction often leaves out the most important characteristics of people's health, drivers of people's health, which are the social and psychological and behavioral needs, the psychosocial needs. And so, as you can see here, that if you define a group of high-need patients by just their biological conditions, that this exhibit 1 shows that that group is more likely to have social and behavioral needs overall, this from the Commonwealth Fund. And I think that's really important because people would ask us frequently about how to integrate those. There's been a lot of effort in this regard recently. And I think that's been great because it's enabled us to at least start to collect the data. What's missing are the systems that integrate social service and integrated behavioral health that would really allow us to drive improvements for their health. For care coordination and care planning, I briefly mentioned our own work in Care Management Plus. We've seen also a number of really interesting collaborative approaches to this come out of this. We found a number of articles related to this. This is an example of one that came out of primary care practices in England, and they used the 3D approach, which was really sort of comprehensive care planning with some tools and an integrated team. And they actually found quite a bit of improvement in terms of people really feeling that they were talking about the things most important to them, which is quite an important part, I think, of this as people have complex care needs. So in addition, transitions of care are often places where HIT could make things better or worse. So I think we could do a lot more in terms of care coordination by enhancing our ability to transfer information about not only sort of the updated care plan, but something that quantitatively or in a structured way assesses needs and goals for the patient, as well as free text for their own needs, and then has a way to transfer that. And there's been a lot of effort in that, but we have a long way to go. HRQ and some other agencies have funded an effort called the eCare Plan that's really trying to bring data together around goals and preferences, around health and social concerns, and interventions and outcomes, in addition to integrating information about the care teams to understand how we can enhance care planning when people have complex needs. Now, this is an application that uses 21st Century Cures new information exchange standards to make it not dependent on a single EHR, but actually can drive data from multiple places. This would enable things that summarize data in different ways, like these care plans, to integrate them together. This is other work we did in structured clinical information, patient summary sheets to facilitate structured conversations. There's been many examples of this. And in it, we really found that we could take some data that we knew to be pertinent about this patient, but like reminders about guideline-based care, but also about goals. And I think that part is something we're really spending some time trying to figure out how we can capture those and exchange them easily. Finally, we looked at systems that help with self-management supports, because a lot of people with complex conditions want to be at home and need help for them and their care partners in home supports. And the iTeam effort was one good example of that from the reviews that we did, that showed that, telemonitoring the devices, remote nurse with sort of multi-disease protocols could really impact quality of life, as well as problem solving, which I think is a really important part of this for mental health, ADL support, and individual condition support as well. Now, what are the problems? So data quality is a big issue. And one of the things that's not always obvious to people is that in our electronic health record systems, we capture data for a number of purposes, but often for billing and documentation related to that. And there's just a minimum in there for any particular engagement with the system. And so we did a study looking at about 1,500 patients with about 2,000 conditions. And we found about 30% of those conditions did not have adequate information to back up that conditions, especially when you're trying to do care planning. So it was just a single code in the chart with no other mention of it that was sufficient. And this is really important. One of the conditions we looked at is dementia that we've done more work on. And people sometimes just came in reporting, subjective memory complaints. That's not severe cognitive impairment without further workup, but somebody would put dementia on the chart. And sometimes it was to rule out conditions or other issues. So what we found also is the data is really fragmented within that same chart, that it might be in the problem list, it might be in the medical history, it might be recorded as billing encounters. And actually, by combining this all together, we got most of the conditions, but we also were wrong more often where we didn't have backup for the condition that was listed. In addition, we did a study looking at follow-up. That fragmentation also occurs over time. Looking at people with mild traumatic brain injury, we found about 20% of them in our system after they were seen by us had no follow-up listed. Now, they could have gotten follow-up elsewhere, but we didn't know that. But the people we did know have follow-up, we saw a much higher incidence of mental health conditions and needs than we would have expected. And so I think sometimes we need to really think hard about what kind of systems we're building with HIT that encourage this kind of follow-up given the gaps. One of the things that we are working on through the eCare Plan effort is actually bringing together all the data from these disparate sources and then trying to figure out how to prioritize it. This really complex looking slide basically says we can use these new information exchange standards to bring all the data together from the patient and then store it in a research data store and then try and understand what's most important when so that we can help future systems improve. The final sort of cross-cutting issues are about ethics and bias. So there are biases inherent in our society and health system inequities that exist. And sometimes our HIT amplifies this in several ways. So here on the right-hand side, this figure shows a paper by Obermeyer that indicates when people are risk stratified for utilization or cost of healthcare. Here it shows Black and white patients. In this example, we're at the same level of overall risk and we're defaulted in the program about the same level. But on the left side, Black patients had much higher incidence of hypertension and diabetes severity. And that was a big problem because those are the kinds of things you'd address and try and limit the bad outcomes that come from untreated hypertension and diabetes, but they weren't getting identified at a similar rate. That was because they had lower access to care. And so were predicted to use care less because they couldn't afford to for a variety of reasons. In addition, HIT can add a lot of complexity. I think we've seen this. They add layers to the workflow, can cause a lot of burnout. And we really have to think about how are we using HIT to make sure everyone has a good experience. Another issue in equity is digital divide, the idea that some people have less access or less able to use these kinds of tools, especially when we're patient-facing and patient-centered. So in a study that showed that a low percentage of patients used the patient portal, they found that lower education and older age meant you were less likely to use portal use, as well as a lower percent of Hispanic patients. And we've looked at this at our own institution that has a much higher portal use. We found exactly the same trends. And then also just where you live matters. People in rural areas might have lower internet broadband access, for instance, and that definitely lowers their use. So what's next? What would I leave you with? What are we really working on? I would say there's sort of 5 grand challenges that we should expect. One is that there's a lot of data. Most of it's not that useful. When you're sort of reviewing for patients that you're going to care for, you're often sort of using a filter to understand what's most important for what's going on with this person, how should I tailor what I'm doing? And we can do a lot now, I think, with our newer tools and algorithms to summarize and provide things at the right level. To simplify, we can actually translate our jargon into much more understandable text through automated tools. We can also be thoughtful about people who don't understand numbers or graphs very well. Sometimes we rely on those. We can also help prioritize by learning from the way that people interact with systems. We can adjudicate. We can help facilitate adjudication by having people tell us what's wrong and what could be better through and recording that. And then finally, I think the most important thing is HIT should enhance decision making that's concordant with the person's goals and aligned with evidence-based practices. And we really need to focus on how are our systems helping to make that easier. So that is all I have. I appreciate. Here's my contact information. Thank you so much.